So our last video focused only on inspiration. This is going to focus on expiration and the rest of the pulmonary ventilation. So it's very important for you to understand this diagram and how atmospheric and intrapulmonary pressures interact so that it allows inspiration and expiration. So definitely try to understand this. So during relaxed breathing, this is a pass of expiration. This is a passive process that's achieved mainly by the elastic recoil of the thoracic cage. So kind of think of when you snap a rubber band and it recoils. That recoil then compresses the lungs and the volume of the thoracic cavity decreases. This raises the pressure within the lungs, or the intrapulmonary pressure, and makes airflow out of the lungs because of the pressure gradient. During forced breathing, accessory muscles act to further raise intrapulmonary pressure, and that forces more air to be expired. So during a pneumothorax, which is a pathology, this is the presence of air in the pleural cavity. This occurs when the thoracic wall is punctured, and inspiration will suck air in through the wound into the pleural cavity, allowing that potential space that's normally has fluid in it. It then becomes air filled. So this loss of the negative intrapleural pressure allows the lungs to recoil and then can make them collapse. An atelectasis is the collapse of part or all of the lung and can result from airway obstruction as blood absorbs gases from blood. So think about a balloon losing air, and the lungs are kind of similar. So airflow is also prone to resistance, so that increasing resistance will then decrease airflow. This is similar to blood flow. So two main factors influence airway resistance: the bronchial diameter and pulmonary compliance. So the diameter of the bronchioles matters, with bronchodilation increasing the diameter of the bronchus or the bronchiole, and this can be achieved through epinephrine and sympathetic nervous stimulation, which allows for dilation and increased airflow. On the other hand, bronchoconstriction decreases the diameter of a bronchus or bronchiole, and this can be achieved by histamine, parasympathetic stimulation, cold air, or chemical irritants that stimulate bronchoconstriction. This acts to decrease airflow. So suffocation can occur with extreme bronchoconstriction during anaphylactic shock or asthma. Additionally, pulmonary compliance plays a role in airway resistance, and this is the ability or the ease with which the lungs can expand. So the change in lung volume is relative to a given pressure change. This compliance is reduced by degenerative lung diseases where there might be stiffened scar tissue stiffening the lungs. So this means that they're not able to function the way that they should. Compliance is also limited by the surface tension of water within the alveoli. Under normal circumstances, the alveoli secrete a surfactant that disrupts the hydrogen bonds between water molecules and reduces surface tension. So it plays a very important role. The surfactant plays a very important role in pulmonary compliance. We can see this in babies with infant respiratory distress syndrome, where they lack surfactant and need to be given artificial surfactant until they can make their own. Basically, this allows the alveoli to function the way they should. So alveolar ventilation is an important concept. Only air that enters the alveoli is available for gas exchange. So this means that not all inhaled air is able to get to the alveoli. So about 150 milliliters fills the conducting zone of the airway, which is anatomic dead space, meaning that there's no gas exchange. The amount of anatomic dead space can be altered somewhat by sympathetic and parasympathetic stimulation. So sympathetic dilation would then increase the dead space, but it would allow greater flow of air. So it does have some benefits. However, in some pulmonary diseases, some alveoli are unable to exchange gases, and this gives rise to the concept of physiologic or total dead space, which is the amount of anatomic dead space within the conducting zone plus any pathological alveolar dead space, and basically tells you the amount of tissue within the respiratory system that does not allow for gas exchange. So this means that if a person inhales 500 milliliters of air, but 150 stays in that anatomical dead space, then only 350 milliliters reaches the alveoli and allows for gas exchange. So you can see what this is by looking at the alveolar ventilation rate, which is the air that ventilates the alveoli and times the respiratory rate, which will give you the amount of air that's ventilated by the alveoli per minute. This measurement is really important and relevant to the body's ability to get oxygen to the tissues and to dispose carbon dioxide. It also gives you the concept of residual volume. So this is the amount of air that can't be exhaled even with maximal effort. So this residual volume just stays within the lungs. So to measure respiration is called spirometry. So you use a spirometer, which is a device that recaptures exhaled breath and records variables like the rate and depth of breathing, the speed of expiration, and the rate of oxygen consumption, and gives you a nice little graph, which we'll see right here. So this is the graph that you would use. So within this is the tidal volume, which is located here. This is the amount of air that is breathed in and out under normal circumstances. Okay? So then you also have the inspiratory reserve volume, which is air that's in excess of the tidal volume that could be inhaled with maximum effort. So when you take a deep breath in. You also have the expiratory reserve volume, which is air in excess of the tidal volume that can be exhaled with maximum effort. So when you breathe out with force. So here we can see them here. So you can see the tidal volume right there. In excess of that tidal volume is the inspiratory reserve volume. So this is the amount that you can forcefully breathe in. And then you also have the expiratory reserve volume that you can forcefully breathe out. You're always going to have some of this residual volume that cannot be breathed out of the lungs. And this is so that you prevent a lung collapse. Together, the total lung capacity, this makes up the total lung capacity. So you can see the inspiratory capacity plus the functional residual capacity, which is the amount that could be breathed out, as well as the vital capacity here, which is the amount that you're actually breathing in and out during forced respiration. So again, with spirometry, the residual volume is the air that remains in the lungs after maximum expiration. And this allows for some gas exchange with blood before the next breath of fresh air. The vital capacity is the total amount of air that could be inhaled and then exhaled with maximum effort. And the vital capacity is important in measuring pulmonary health. The inspiratory capacity is the maximum amount of air that can be inhaled after a normal tidal expiration. I won't be asking you for these exact equations, but do look back at that graph that we showed and try to make sense of them so that you can understand what's going on when, because it does get kind of confusing. So the functional residual capacity is the amount of air that remains in lungs after normal tidal expiration, whereas the total lung capacity is the maximum amount of air that the lungs could possibly contain. So like I said, spirometry is the measurement of pulmonary function, and this aids in diagnosis and assessment of restrictive and obstructive lung disorders. Restrictive disorders are those that reduce pulmonary compliance, and they limit the amount to which the lungs can be inflated. Remember, pulmonary compliance is how well the lungs are able to be filled. So this is any disease that could produce pulmonary fibrosis. So this would be any kind of scar tissue within the lungs. So this could be found with black lung disease or tuberculosis. Obstructive disorders like COPD, which is chronic obstructive pulmonary disorder, are those that interfere with airflow by narrowing or blocking the airway itself. And this makes it harder to inhale or exhale a given amount of air. Different kinds of COPD include asthma or chronic bronchitis, as well as emphysema, which combines elements of both restrictive and obstructive disorders. So the forced expiratory volume is the percentage of the vital capacity that can be exhaled in a given time interval. So that's given as a percent. The peak flow is the maximum speed of expiration, and this can be measured by blowing into a handheld meter. A minute respiratory volume is the amount of air that's inhaled per minute, which can be given by the tidal volume times the respiratory rate. The maximum voluntary ventilation is the minute respiratory volume during heavy exercise.